Let's now talk about the elimination of drugs. In zero-order elimination, the elimination of a drug is constant regardless of the concentration of the drug in the body. A constant amount of drug is being eliminated per unit of time, resulting in a nice linear decrease in plasma concentration. For example, aspirin in the body would be eliminated at the same rate regardless whether 81 milligram tablet was given or a couple 325s were given, since the body will eliminate the aspirin at a nice steady pace. Zero order elimination is less common than first order elimination, which we'll talk about next. So now that you're experts on zero order elimination, what should you remember for boards? What are the main medications that are going to be eliminated via this zero order elimination? Well, the high yield drugs that you should remember are going to include phenytoin, aspirin, and ethanol. Alright, so how are you going to remember this for test day? Well, in zero order elimination, the zero kind of looks like a pea. Remember those green peas that you didn't really eat on your plate when you were a kid? Well, since it's a zero, a pea looks like a zero. We're talking about zero order elimination. PEA, phenytoin, ethanol, and alcohol. So that's an easy little kind of back way to remember it. So you can think of zero order elimination like draining a bathtub. It doesn't matter how much water you have in the bathtub, whether it's 3 inches or 3 feet of water, the amount of water that'll actually drain per second is dependent on the size of the drain opening. So regardless of how much water you have in that bathtub, it will drain at a nice constant rate. So now that we've talked about zero order elimination, let's talk about first order elimination. In first order elimination, the rate of elimination is proportional to the concentration of the drug that's actually in the body. So a constant fraction of the drug is being eliminated per unit of time, resulting in an exponential decrease in the plasma concentration. Simply put, for first order elimination, if there is more drug in the body, more drug will be eliminated. And then if there's less drug in the body, less drug is being eliminated. So note that the first order elimination has a nonlinear curve compared to our zero elimination. So most drugs are going to be removed in the body via first order elimination, except for these 3 main ones, these high yield ones for the USMLE. So what you can do is, to make your life easier, just remember that the 3 main drugs removed via zero order elimination include phenytoin, aspirin, and ethanol, and then all other drugs can be assumed to be first order elimination drugs. Now let's go over how drugs are cleared by the kidney. The key area here is going to be our glomerulus. Thinking back to physiology, what kind of molecules cross the cell membrane the easiest? So let's draw a little cell membrane here, a little phospholipid bilayer going on. Maybe one more set here. So we have 2 molecules. Is this neutral molecule or is this charged molecule going to be able to cross easiest? Well, it's going to be our small, non-polar molecules that cross easiest. Remember, our neutral particles cross the cell membrane much easier than our charged molecules. So the same principles are going to regulate the drug reabsorption once the drug is actually filtered from the glomerulus and then into the lumen of the nephron here. As you'll see in the renal section, the brush border cells lining the lumen of the nephron will try and reabsorb any filtered drugs. Ionized species, or our charged molecules, are actually going to get trapped in the lumen and then passed in the urine and then cleared quickly because their charge prevents them from actually crossing this plasma membrane. Neutral molecules, on the other hand, can be readily absorbed across the tubules. Therefore, if a drug needs to be cleared quickly from the body, the urine pH should be adjusted so that the drug is in its ionized form and it will be trapped in the urine for elimination. Weak acid drugs, such as our tricyclic antidepressants, methotrexate, and aspirin, are ionized in basic urine as shown in the following equation. Why would we give a basic compound to treat a weak acid drug overdose? Well, the weak acid is going to be lipid soluble. So this is going to be our weak acid, and that is going to be lipid soluble, and it can cross that membrane. While the ionized form, this form right here, is going to become trapped. Remember, it's going to have a charge, it's not going to be able to cross the membrane. This is why overdoses of drugs that are going to be weak acids can be treated with bicarbonate. Now on the flip side, we have our weak bases, including like amphetamines, for example. Now these will become ionized in acidic urine as shown in this equation. So here we see weak bases, which are going to be trapped in the ionized form here. So we have our ionized form trapped, and these will be lipid soluble in its weak base form. So hence ammonium chloride is going to be used to treat an overdose with a weak base such as amphetamines. So this will create the ionized version of the weak base here. It'll become trapped in the urine and then eliminated in the urine. Let's do a flash quiz to see how the concept of urine pH and drug elimination could appear on the USMLE. We have a young college student who has overdosed on a combination drug Adderall. How do you treat this overdose? Here, I'll help you out. Adderall is a stimulant drug that is an amphetamine. So like I said on the previous slide, amphetamines are a weak base and an overdose is going to be treated with ammonium chloride. The body increases the excretion of toxins and drugs by transforming them into a less lipid-soluble and more ionic particle. This is the basis of drug metabolism and occurs primarily in the liver. There are two types of drug metabolism that the boards are going to cover. It's going to be phase 1 and phase 2 metabolism. Phase 1 metabolism consists primarily of reduction, oxidation, and hydrolysis reactions. Now these are going to usually yield slightly polar water-soluble metabolites. These metabolites are often still active. And when thinking of phase 1 metabolism, I want you to think of the cytochrome P450 system. Now the cytochrome P450 system is a series of enzymes found in the endoplasmic reticulum and mitochondria of the liver, and these help metabolize drugs. We also have phase 2 metabolism. Now phase 2 metabolism includes your acetylation, the glucuronidation, and lastly our sulfation. So phase 2 metabolism is characterized by, these three reactions, and usually they yield a very polar, inactive metabolite that can be excreted by the kidney then. So when thinking of phase 2, I want you to think of conjugation. So it's a simple way to think of conjugation. We'll think of it as a means of joining two things together. Now, to illustrate the concept of metabolism, I have an example here to show how benzene gets turned into a phenyl sulfate by phase 1 and 2 metabolism. So first, we have our benzene here, and it's going to get turned into a more water-soluble molecule via phase 1 metabolism in the P450 system. So at this point, the metabolite, or phenol in this example, may still be active and have some unique actions on the body. The product of a phase 1 reaction is simply a modified version of the parent compound here. So next we have our phase 2 reactions take place. So a polar group is going to be added via sulfation. So let's add some sulfation and under phase 2, and that's going to produce a polar inactive molecule that can then be excreted by the kidney. So we have our phenyl sulfate. So let's turn all of this into a nice clinical application. People who are slow acetylators have greater side effects from drugs like isoniazid, a tuberculosis drug, because of the decreased rate of metabolism. Because of this decreased rate of metabolism, there tends to be a higher concentration of drug in the body given the same dose and frequency as a normal acetylator. Typically, the Caucasians and African Americans tend to be the slow acetylators, while the Asians are usually the fast acetylators. However, acetylation speed is genetically determined, and this is just generally a rule of thumb. So now I have a question for you. Given a couple options, we have a 6-year-old, we have a 30-year-old, and we have a 70-year-old. So you have these three patients, and they're all taking isoniazid. Which patient would you expect to have the highest risk of side effects while taking isoniazid? Well, geriatric patients lose phase 1 metabolism before phase 2 metabolism. You can remember this by using the memory aid, geriatric patients retain gas. Gas is going to be an acronym for the phase 2 conjugation, so glucuronidation, acetylation, and sulfation. Hence, a 70-year-old patient would have a higher risk of having side effects due to reduced drug metabolism after taking isoniazid. More drug is going to be in the body, so elderly patients will actually be at a higher risk for side effects. Therefore, elderly patients, especially those with kidney or liver problems, may require reduced doses of some medications. As discussed earlier, we now return to the concepts of efficacy and potency. Let's quickly talk about agonists though. An agonist binds to a target receptor and stimulates an effect. So it's going to stimulate receptor. Okay, so some agents tend to stimulate the receptor and cause a full effect. These are called full agonists. On the other hand, some drugs stimulate the same receptor but don't create as big of a downstream effect as that full agonist would. These drugs are going to be termed partial agonists. So how do agonists play into this picture of efficacy? So efficacy is going to be the maximal effect a drug can produce. So efficacy is defined as the maximal effect a drug can produce irrespective of the concentration required to achieve that effect. The efficacy of a drug can be thought of as the Vmax produced by the drug, or how high up on the y-axis a reaction takes place. Partial agonists have less efficacy than full agonists, meaning partial agonists do not produce as big an effect as a full agonist would. These partial agonist drugs bind the same receptor, but when they stimulate these receptors, the effect won't be as big compared to when a full agonist binds this receptor. Thus, partial agonist will only have a partial stimulation or a decreased efficacy. So we now shift to the concept of potency. So potency is the amount of drug to achieve a given effect. So potency is defined as the amount of drug needed to achieve a given effect. Potency of a drug is directly related to the drug's affinity for its target receptor. The higher the affinity for the receptor, the higher the potency of the drug. A more potent drug will be shifted to the left on our graph because less drug is going to be needed. A less potent drug will be shifted to the right on this graph since more drug is needed to achieve this target effect. So here's a scenario for you. We have two drugs, drug A and drug B. We'll plot them out on our chart. So we have two drugs. On our y-axis, we have our percent of our maximal effect, while on our x-axis, we're going to have our drug dosing. You're tasked with trying to figure out how much drug will you need to produce 50% of the drug's maximal effect, or half of the Vmax to put it another way. So here's our box that we're going to use. Drug A requires 0.5 milligrams to produce half of its Vmax. So here is our drug A, our red line here. Drug B, on the other hand, requires 1.5 milligrams to produce half of the Vmax. So let's draw that in to our chart here. This is the question that I want you to answer. Which drug is more potent? Well, even if you're guessing, it's a 50-50 guess, but I don't want you just to guess, I want you to know why. Drug A will have a higher potency. Remember that an increase in potency means less drug is needed to reach a given effect. So then we get to the big question, are efficacy and potency related? Well, the answer is not really. A drug's efficacy and potency are independent of each other. Each drug is unique and could have any combination of the two. So just for a quick example here, let's draw a Punnett square, everybody's favorite. Are a drug's potency and efficacy related? So up on the top we'll have efficacy, and down here we'll have potency. Alright, so really we could have any combination. We could have high, high, low, low. So high potency versus low potency. So we could have a drug that's high, high. We could have a drug that's high, low. So a high in efficacy or low in potency. Same with vice versa, and then both could be low, low. So remember, bottom line that I'm trying to get at here is each drug has its own unique combination of potency and efficacy. If one is highly potent, it may or may not be efficacious, and then vice versa.